Hello, everyone, and welcome to our first AL Pacific Northwest support meeting. This is our second local meeting. We had one for ATTR a few weeks ago. We really appreciate more than 30 of you joining us today. All our previous meetings can be seen on our website, amyloidosissupport.org. Click on the webinar link. And you can also see them in our new YouTube channel, youtube.com/amyloidosis support groups. In the chat section today, Paula is going to be putting up various links that will help you. One of them will be for our Facebook group, our YouTube group, and other things. We'll talk about more later. Okay, be sure and subscribe to our YouTube channel. We hope to be able to resume some live meetings in 2022. We realize that the main thing lacking from these webinars is the patient-to-patient contact. And we do have our Facebook groups that really kind of help in that area. We have more than 4,000 registered in our AL support group. There are certain questions you have to answer. We do vet everyone that wants to join. It is a private group. And the link for that will be put on our chat section as well today. So we do ask that you stay out of the chat section. If you have any questions, you can post it on the Q&A section, and we'll get to them later on, but do know that the questions that were emailed into us will get a priority first. We won't be able to answer all the questions today. At least that's what our history tells us with these webinars. So we do ask that you be patient, and we will get the doctors to answer other questions that we don't get time for. Also, we have a short survey at the end of today's webinar, and we ask that you all take part in it because it does help us in planning for future webinars. So we ask that you, even if you have to leave early, you will have an opportunity to fill that out. In the control room today, we have our executive director, Paula Schmidt. And Paula is also our financial aid expert. So Paula, I'm going to ask you, is there any access to financial aid for our AL patients these days?
Yes, there is for patients that also have myeloma or a blood cancer such as lymphoma. They will have an opportunity to see if they qualify for financial assistance copay plans from the Leukemia and Lymphoma Society. They have up to $11,000 that they give annually to patients that qualify both financially and based on their disease. But you must have myeloma or a cancer along with the AL to qualify.
And then do they just go to the LLS website and find financial aid?
Yes, and I will post those links in just a few minutes.
Super, that'll be in the chat as well. Wonderful. Okay, we have a wonderful group of guest panelists today. We always do. We're very lucky in that area. Our presenters today are Dr. Eva Medvedova from OHSU, Oregon Health and Science, along with Dr. Ahmad Masri, cardiologist from OHSU. From the University of Washington, we have Dr. Sarah Lee. I joked one day and asked her if she baked, and she never responded to me, so okay. And Dr. Ed Libby. Okay, and cardiologist Dr. Richard Cheng. Also joining us to help answer your questions is Dr. Bilal Malik from the University of Washington. And later on, we'll be visited by Dr. Johnathan Wall from the University of Tennessee. And he'll be filling us in on his imaging study. Okay, there'll be don't forget that survey when this is over. I just, can't say enough how important these are to have you fill them out. We'll be working off a treatment chart today. Bob, can you get that treatment chart up so people can see it? There you go. Those of you who have come to our meetings have seen these before. You can take a picture of it now, or Paula's going to put a link for that, or Bob's going to put a link for that chart in our chat section so that you can click it on and have access to it. This way you'll be able to spell the various treatments that we're talking about, and you'll know what we talked about when we refer to the different columns. This is especially important for you newbies who aren't used to these things. Thank you so much, Bob, or Paula, whoever put that up. Okay. So right now, we do want to tackle some of these treatments. They're so important. And the first one, of course, that everyone talks about, and so many people seem to be put on, is CyBorD or CyBorD and Dara. So to talk about that, because there's confusion in that area. We know that Daratumumab has been approved. It's the first drug approved for AL amyloidosis, but it's been approved for newly diagnosed patients. Yet we see many patients that are what they call relapsed or refractory also put on it. And some might have issues with their insurance companies even. So let's have Dr. Libby start with this. Dr. Libby?
Hi, Muriel. Thanks for allowing me to speak today. So that's a great question, and this is a unique situation. Most of the time when new drugs are approved for different diseases, different cancers, they're approved for relapsed patients first. And that's usually because much of the time we already have reasonably good treatments for these diseases. So the FDA says, since you already have a decent treatment, any new drug that comes along has to be for relapsed patients so that everyone gets the good treatment first before you give them this new treatment. But that wasn't felt to be true. It's really not true in AL amyloidosis. The need is so great to improve the outcome for patients with light chain amyloidosis. The FDA allowed the approval to be for frontline patients. Normally, you would not do a study like the one that's been done to get this drug approved for newly diagnosed patients. You would normally not do that. It would be for relapsed patients only. But the clinical need was felt to be so great for amyloid in the newly diagnosed situation, the FDA allowed this to be done. So it's quite unique. I think I'm convinced that this will be the new standard of care and that everyone from this point on in the United States will be treated with this combination of CyBorD and Daratumumab. And I strongly suspect that it's going to get far easier to obtain Daratumumab for patients with relapsed amyloid than it was up until a month ago when Daratumumab was approved for amyloid. And that's for a lot of reasons, but I just think the insurance plans are going to tend to approve it even in the relapse situation. Whereas last year in 2020, you often had to really battle and sometimes simply could not get Daratumumab for a patient with amyloid. You just couldn't get it no matter how many appeals you put in. So unique situation, long answer, but I'm thrilled that this has come about.
Thank you. Dr. Medvedova, Dr. Lee, Dr. Malik, can we have you, put your video on? And I'd like to get, I'd like to get your 2 cents, Dr. Medvedova. One of our questions that someone asked was Dara as a single agent chemo, she called it for retreating comeback amyloidosis. We know she meant refractory or relapsed amyloidosis. Is it being used? So is it being used as a single agent?
It is being used as a single agent. We know from retrospective studies that it is effective. It induces overall response rate for 70–80% of patients. And we are also, from these retrospective studies, seeing that patients are having organ responses as well.
Okay. And Dr. Lee? Okay.
Sure.
Do you have anything to add to that?
Yeah, I think one of the most exciting things is just the speed of how quickly people tend to respond. We see hematologic responses even after just a couple cycles, even in patients who are relapsed and refractory. So getting Dara either as a single agent, like Dr. Medvedova said, or even in combination in the relapse refractory setting, still we're seeing people who have a really good, rapid, quick response, which is always the goal. So it is a very exciting treatment option.
Okay, so can we say, ask all of our hematologists here, would you say when you get that new patient with AL amyloidosis, and we'll discuss stem cell transplants later, of course, but let's say that for whatever the reason a stem cell transplant is out of the picture, is CyBorD with Dara the first thing that you're offering them, Dr. Lee?
I think a clinical trial would be, ideal to first see if there is a clinical trial for newly diagnosed patients. And right now we're actually lucky enough to have that. I think we'll, Mira, I know it's on your agenda to talk about a little bit later, but, I think that would be the first option, is to look for a clinical trial option. And if not, then absolutely, I think Dara-CyBorD would be, the standard of care and what I would recommend patients to go on.
Dr. Medvedova.
I completely agree with that. So outside of clinical trials, Dara-CyBorD is our first choice.
Okay, and Dr. Libby?
Absolutely. We want to use evidence-based medicine, and now we soon will have the manuscript published for the study, and this is going to be a large, well-done trial. So we're going to have evidence-based medicine telling us that this is a safe and very effective approach.
Okay, so if we take a look at our chart, okay, we see that Cytoxan is one of the drugs in the CyBorD cocktail, and Cytoxan is an alkylator that, frankly, before CyBorD, we never really heard a whole lot about. We heard a lot more about melphalan, okay, because melphalan in high doses was used in stem cell transplants, and it was also used orally back in the early days before we had all these other drugs. So can we talk about alkylators? How do they work? Let's start with you, Dr. Libby. How does an alkylator such as melphalan or Cytoxan work? What does it do? And we know we can trust you to handle lay language.
Well, they interfere with DNA in the cell, and so the old classic chemo, when you say chemotherapy, you're really referring to drugs that interfere with cell reproduction by damaging DNA in the cancer cell. The downside is they affect DNA in non-cancer cells as well. So when you use just standard chemotherapy, like classic chemotherapy, like Cytoxan, you're injuring normal and abnormal cells to a much higher degree than you do with our newer targeted therapy. So Cytoxan is a classic drug that's been around for decades and decades. One thing I'll mention about it, it is true chemo, but we give this is a small dose that we use in amyloidosis. And so we use 10 to 20 times that dose often for other tumors. So it's a small dose, but it synergizes very well with Velcade and steroids.
Okay, so that takes care of melphalan, but another one in our chart, and again, if you go to the chat section for our listeners and click on the link, you'll be able to see the chart. We see is bendamustine, and that was one that was behind the Iron Curtain for a long time, and now it's made its appearance here in the US. And we see it used a lot, I think, with lymphomas. But now we're seeing, we have patients that say they were on bendamustine when nothing else worked. Are you using bendamustine at your place? We'll ask you, Dr. Libby, since you're on the screen.
Yes, we have used bendamustine for amyloidosis. I use it fairly often in multiple myeloma. And so if you remember that myeloma and amyloid are closely related, if it works in myeloma, you might expect that it would have an effect in amyloidosis as well. I don't use it for newly diagnosed patients in myeloma or amyloid. It's more of a later down the road if things are not working. And it's not as effective as, certainly I wouldn't expect it to be as effective as CyBorD Dara, but in patients who've relapsed and other drugs aren't working or aren't tolerable, it is a good choice.
Dr. Medvedova?
Yes, we are using also bendamustine. The major side effects are lower blood counts with this treatment. Sometimes patients could experience skin rashes, nausea, vomiting are not the most prominent findings from it.
Great. Okay, and Dr. Lee?
Yeah, I would agree. And I think I would say similarly to cyclophosphamide, we use it in doses that are generally well tolerated. Most people are not going to have to worry about things like losing your hair or throwing up, being in the bathroom, like what people expect when they think about chemotherapy from watching movies and things like that. So overall, it is still something that is generally well tolerated. And like Dr. Libby said, we use it in people who have relapsed and who may be refractory to other treatments, who've had multiple different lines, and they're still able to tolerate it. So.
Okay, well, that's going to take care of the alkylating for now. We have one more to discuss, and I call it Mel Fluffin, but that's because I'm a marshmallow fluff person. But we'll leave that one to later when we discuss stem cell transplants, okay? So the BOR in CyBorD we know is bortezomib, also known as Velcade. So that would be in the column for proteasome inhibitors, okay? So, and Velcade really was the dawn of a new age of treatments in AL amyloidosis. I know it was pretty exciting. And of course, Dara's the new kid on the block. So, but we were used to that excitement because Velcade really did it for us back in the day. What about carfilzomib and these others in the list? Can Dr. Lee, we have you. What about carfilzomib?
Yeah, I think, carfilzomib and the third one, which is ixazomib or Ninlaro, are kind of the next generation proteasome inhibitors that came out after Velcade. I think that, Velcade is still kind of the standard of care, first thing you would try, but I would think more along the lines of side effects and what kind of symptoms people may have to begin with. So we know that with Velcade, it can cause, there's a big risk for neuropathy, and patients with amyloid may present already with pretty debilitating neuropathy. So it might not be a drug that you want to use in the first sign if patients already have that as a symptom. So that might be a situation where you might consider something like carfilzomib or ixazomib instead. But the things to consider with carfilzomib in particular is that it is cardiotoxicity. And again, if patients are presenting with cardiac amyloid or having already, significant compromise of their heart function, that might not be something to consider. So, just kind of evaluating the toxicity profile when picking the right proteasome inhibitor.
Okay, now you talked about Ninlaro, which is kind of like they don't like us to say it's oral Velcade, but to me it's like an oral Velcade. But then we have what are those two other guys? Something is Mib and oprozomib. What are they?
I might toss that over to Dr. Libby or
Dr. Libby.
Well, marizumab is a proteasome inhibitor related to carfilzomib and Velcade that I think is approved in Australia, but it has not been approved in the United States or Europe. So it'd be nice if we had it, but we don't. Oprozomib was an oral form of carfilzomib, and so it's not available either. They're still studying oprozomib, but it had tremendous gastrointestinal toxicities when it was initially studied several years ago. We participated in those trials here. So I think those are drugs that may or may not ever really find the light of day in the United States.
Okay, now before we go on to our next columns, I want to. We have our brilliant cardiologist and our wonderful nephrologist with us. So let's talk about side effects. We know for every good thing that happens with a drug, there can be possibly a bad thing that happens with a drug. Okay, so since we have Dr. Malik with us, our nephrologist, okay, the drugs that we've been discussing so far, Dr. Malik, the daratumumab family of drugs, not the we haven't hit the daratumumab, I'm sorry, the alkylating agents and the proteasome inhibitors, those two. Are any of those toxic to the kidneys? You're on mute there, you're not now, good.
So taking the Velcade or the bortezomib first, these are very safe agents in the kidney diseases, and we have not really found any major side effects. In fact, folks who enter into multiple myeloma or amyloidosis with a heavy burden of kidney disease or involvement, bortezomib or Velcade tends to be the first line agent to go to and has shown in trials to have a much superior outcome when compared to other therapies. So from bortezomib and the family of proteasome inhibitors, we do not typically have any major concerns. There are some case reports which are very, very rare where there could be a concern of some microclotting, like small microclots developing in the bloodstream. But those typically are very rare and also cannot completely be ascribed to proteasome inhibitor therapy because there are so many other competing events that are happening at the same time that could be responsible for those side effects. So in general, we can say that as a family, particularly Velcade, bortezomib is very safe. When carfilzomib first came out, there was some concern that in itself could impact kidney function with the art marker, the serum creatinine that we look at was a little bit higher in some patients, but I don't think that it has really borne out that that's a real concern for you. So we have seen folks being treated with carfilzomib without any major impact on the kidney function. With regards to the cytoxan or cyclophosphamide, absolutely. We use cyclophosphamide in a whole host of kidney-related disorders as well. And we use it in, of course, much smaller doses as compared to the oncology world. And here I'm hearing that the doses being used in myeloma and in amyloidosis are also pretty small. So in general, we do not have major concerns with cyclophosphamide either.
Great, thank you. Let's go to our cardiologist. Dr. Masri, are you with us yet? I wanted to ask you about any cardiac adverse events with our alkylating agents or our proteasome inhibitors. So, Dr. Masri?
Yeah, so yes, can you see me? Yeah, so for the proteasome inhibitors, typically they're well tolerated. There have been very, very uncommon reports of people having worsening of their heart failure. The problem is, with AL, there's so much cardiac involvement up front that sometimes it's very hard to separate. But in general, it is very well tolerated for the proteasome inhibitors.
Now I vaguely remember that carfilzomib. There was a study on carfilzomib where there was some cardiac adverse events.
Yeah, correct. I was referring to Velcade.
Oh, okay.
Mainly. So for carfilzomib, yes, we typically don't use it in patients with cardiac involvement because it's been suspected for 7-8 years, even way before the study was released, that there are a lot of side effects. One is worsening heart failure, 2, worsening mortality, 3, increase in pulmonary hypertension incidence. And there was a lot, the main signal was some of the mortality. And so then this was confirmed essentially in the study that was released. And, we typically don't use carfilzomib in patients that I see who have cardiac involvement. Correct.
Okay. And what about Ninlaro, Dexamethasone, the oral drugs?
Yeah, so I have never used it. So as far as I know, and the hematologist on the call can correct me, I've never personally used it with the help of Dr. Medvedova, but I don't think there are major adverse events compared to carfilzomib. I think carfilzomib stands out in that group of medications.
Yes.
Yeah, so Ninlaro is really simply oral bortezomib. It's the same drug, so it's not really a concern. I totally agree with Dr. Masri. So carfilzomib really should be avoided in amyloid in general, unless you're absolutely confident that the patient doesn't have significant cardiac amyloid. So it's something you got to think long and hard about before you give carfilzomib to an amyloid patient.
Thank you. Dr. Medvedova, I picked up from Dr. Masri that you're not a fan of Ninlaro.
Right.
Dr. Medvedova?
I don't know, somehow I have not had the opportunity to use it in patients with amyloidosis. I have used it occasionally in myeloma patients, but not the biggest fan of maybe.
Okay, very good. And Dr. Cheng, any cardiac toxicities that are, that stand out with our alkylating agents, that the melphalan or the cyclophosphamide, known as cytoxan?
Yeah, no, definitely. So I think, this is a very valid question and concern. So with any of these agents, not only for amyloid, but for other cancers, we always worry about potential cardiotoxicity. With alkylating agents in particular, we often see an increased risk for arrhythmias. It's rare, but it does occur. So patients do need close monitoring during treatments. There is a small risk for acute systolic dysfunction where the heart function drops, but it's also exceedingly rare. And it's not something we recommend routine monitoring for, but if someone has symptoms, then we need to bring them and get an echocardiogram, ultrasound of the heart, and then treat it appropriately. I just want to make one comment about, discussion for the carfilzomib. So I've seen quite a few patients receive it. I think when patients get symptomatic and short of breath, it's important to differentiate between shortness of breath due to cardiac versus non-cardiac causes. I've seen a lot of non-specific shortness of breath. I'm sure Dr. Libby can elaborate on that. I've seen a number of patients get sent to me where we complain shortness of breath, and we do a thorough cardiac workup, and it seems like they're okay. So it seems to sometimes cause symptoms even in the absence of overt cardiac dysfunction.
Okay, anyone wish to comment? Dr. Libby or anyone?
One thing I was going to say about ixazomib or Ninlaro is that there was a trial looking at the drug in relapsed amyloidosis, and it was not a successful study for the Ninlaro or the ixazomib. It didn't achieve the statistical goals that they had hoped. So I use it very rarely in myeloma, and I have not used it in amyloid and would tend to try not to use it.
Okay, anyone else have any comments on the alkylating agents and proteasome inhibitors before we move on? Okay, well, let's take the obvious one, dexamethasone, okay, Decadron or whatever. Okay, now we know that at one time they actually used dexamethasone or without using any other drug because it had some sort of activity against the plasma cells, which is pretty exciting. And now I guess it's used as sort of a booster rocket for the chemotherapy. So, but we also hear people complaining that they have fluid buildup, that they're cleaning the house at 3 in the morning, that they have a crash after 3 days. So, and you can't use as much as you use for multiple myeloma. You have to cut that in half for many AL amyloidosis patients because of the cardiac issues. So let's go with all of you and see what you have to say about dexamethasone, the good guy who can also, I guess, be a bad guy sometimes. So Dr. Libby, go for it.
Well, the most important thing is that dexamethasone does work on its own against amyloidosis or multiple myeloma, and it synergizes with other drugs. So if you use any of our drugs, the other drugs we've talked about, like Velcade, if you use that just by itself, it is not that effective alone. But when you add dexamethasone, it significantly improves how effective the Velcade is. So we know that if we abandoned Dex because of all of its side effects, we would lose a significant amount of efficacy of the CyBorD, of the Cytoxan and the bortezomib, or the daratumumab. None of these drugs alone is that effective. It's in combination that you really see high efficacy. So right now, not having a replacement for Dex, we're stuck with it to get these really great response rates. On the other hand, it's a terrible drug. It has lots of bad side effects like weight gain, edema. Patients especially with amyloidosis, 2 out of 3 of them have cardiac issues, and it causes fluid retention and can exacerbate your congestive heart failure or your renal dysfunction. If you have 2 out of 3 people roughly have renal dysfunction as well. So, and it causes fluid problems. So it's a bad drug for amyloid patients. Unfortunately, it makes the other drugs work better. So we're just stuck with it. The last thing I just would say is that we need to dose, in my opinion, we should routinely dose amyloid patients at 50% of the standard dose, which is 40 milligrams is the standard dose that's often recommended. I always give 20, and I often cut that dose down if it have side effects from that. Of course, the other thing is the road rage or the steroid rage. It makes people irritable, hard to live with. And they're up all night long, and it messes with your bones.
But does it also mess with your muscles, or is it?
Yes, yeah, muscle atrophy. Yep.
Now, when you said the standard is 40 milligrams, but often cut it in half, or usually cut it in half. Is that per week, or is that per?
Per week.
Per
40
week.
milligrams per week would be a standard dose. I cut it to 20.
Okay, and Dr. Medvedova, let's hear what you have to say about dexamethasone. Friend or enemy?
Friend and enemy, but I agree that it's the most challenging, probably, medications of the ones we are using. It makes the side effects of the chemotherapy really be insignificant sometimes in comparison to the dexamethasone in patients with amyloidosis, particularly. I think the psychological side effects are very significant, and the fact that patients cannot relax, and we have to pay really a lot of attention and ask questions our patients about, are they able to sleep, and make sure that they do get the sleep, and then that the following days they don't have the crash as much. I do start typically with also the 50% dose reduced when I'm starting, and I have a very low threshold in my amyloidosis patients to decrease the steroids further if they are having a hard time tolerating the dose that they are taking. And I think the myopathy, what you are referring to, the muscle weakness, is really sneaky. And it's hard to also differentiate in context of the neuropathy, overall generalized fatigue, but it's important to be aware of.
Thank you. Dr. Lee, I see you nodding.
Yeah, I couldn't agree more with both Dr. Libby and Dr. Medvedova. I think a lot of times too, when I talk about the side effects of dexamethasone, I direct it not only to the patient, but also the caregiver who's sitting next to the patient, because they experience a lot of the brunt of that. But I think especially, some of the things to consider, not only the direct side effects that we've mentioned, but, a lot of patients with amyloid tend to be, more mature in age. And so things like having a regular sleep cycle, when that's thrown off, can really cause a lot of other, mental problems, risk for falling, and just a lot of other, complications that we may not really think about that are directly a result of the, the chemotherapies themselves. But yeah, I think a lot of times that medicine tends to be the hardest for patients to deal with.
Okay, and since we were talking about toxicities with cardiac and renal, Dr. Cheng, what are you seeing with cardiac toxicity with these drugs?
Yeah, sure. So as you mentioned earlier, dexamethasone is a corticosteroid. So we see very similar side effects with dexamethasone as well as with prednisone, or essentially any of the steroids in that class. I think one of the major things we deal with is fluid retention. I share a lot of patients with Dr. Libby and Dr. Lee at SSA here, and oftentimes these patients who are predisposed to fluid overload, if they have heart involvement from the amyloid already, it tends to get worse in a cyclical fashion, where after dexamethasone, we often see them retain a bit more fluid, and then it kind of improves over time and then resolves sort of kind of between the cycles. So oftentimes what I recommend is for patients on loop diuretics, such as furosemide or Lasix, bumetanide or torsemide, so diuretics to get rid of the excess water, I'll often have them take a higher dose immediately after the steroids. And sometimes with Dr. Libby, we've had patients where we even give them IV diuretics after steroids to make sure that they get the fluid off and that they don't get the swelling immediately after the steroid administration.
Okay, and Dr. Masri?
Yeah, we do kind of the same. It's one of the major problems in treating these patients, because it can be enough to actually throw them off, and can be enough to make them sick. It can be enough to sometimes, make them even need an admission for intravenous diuretics and, getting the volume off. So we typically have a plan for patients, and sometimes it's tough, so we have to continue to work with them and their, significant other. But typically we have plans where we scale up the diuretics the day of the session as well as the next day. And then we typically have to start scaling back, because you also, if you just go high on these doses of diuretics and water pills, you essentially risk the opposite, which is by day 3 or 4, you're drying them too much, and then you throw them into kidney injury and other issues. So, it is probably one of the most difficult things to deal with for patients with advanced cardiac involvement when they come for their sessions for chemotherapy.
So you have a balancing act here. obviously, because we have heard from patients who say that they've had to take diuretics, but then their blood pressure dips from the autonomic neuropathy or whatever's causing their orthostatic hypotension of some kind, and they're fainting because they don't have enough fluid. Do you have well, let me ask Dr. Malik this, because this would I guess relate to the kidney, and people are always asking who have kidney involvement, how much fluid should I be taking in? Because again, that's a major balancing act between autonomic neuropathy and kidney involvement and fluid and dexamethasone. So Dr. Malik, basically, what do you give for advice there?
Sure. So first, we have to recognize that there are no hard guidelines that you have to hit a certain ounce of fluid intake during the day. So it has to go along with the clinical scenario. So definitely when folks have just gone through a cycle of chemotherapy where not just they have received the dexamethasone, but also IV fluids as well. And so it's natural that they will retain some volume on them. So I would say minimizing fluid intake, maybe cutting into half of what they were usually doing would actually help along at that point. And most amyloid folks usually do experience low blood pressures, be it kidney failure related nephrotic syndrome or be it autonomic neuropathy. And so they have to use diuretics to help get rid of the extra fluid. And yes, the blood pressure, maintaining a stable blood pressure becomes a big challenge. So naturally reducing the fluid intake during those days right after an infusion cycle probably would be the best way to go. In general as well, people ask the same question, should I be drinking 64 ounces, 96 ounces? There is no cut limit on that. And I would also suggest that there is no real data that drinking lots and lots of water will miraculously, make the kidney function better. In fact, it can predispose to more fluid retention, especially in folks who have nephrotic syndrome or who are losing a lot of protein from the kidneys into the urine, and they are more predisposed to fluid retention. So I would say in those folks, a judicious use of water intake that would just take care of their thirst, and that would be the recommendation.
Dr. Malik, sometimes we see people posting in our Facebook group something that I don't understand, so I'm going to hope that other people don't understand it either, because I'm going to ask you, what is IVIG that people get or they want, and sometimes their doctors refuse it, and sometimes they don't. What is that?
I got it. So it's the immunoglobulin, IVIG, which they sometimes get as part of various therapies, sometimes in the oncology world as well as in rheumatologic world and autoimmune diseases and whatnot. So the main concern as nephrologists that we have with IVIG is that the IVIG itself is not toxic to the kidneys. It is the vehicle with which it is given, which is sucrose, which is a very concentrated glucose solution. And that sucrose is taken up by the kidney cells and can be toxic to the kidney cells and can lead to an acute kidney failure syndrome if given in high concentrations and over a very short period of time, like simply dumping into the bloodstream. So we recommend at times that if IVIG is being given to somebody who has a precarious kidney function to begin with, to increase the time interval over which it is administered, or maybe other options are to use a non-sucrose based vehicle, or we've also, I've seen some folks get it subcutaneously as well. So those are some of the ways to avoid the toxicity of IVIG.
Okay, and when would a patient need IVIG, the amyloidosis patient? What would be going wrong with his body or her body that all of a sudden that you would decide they need IVIG?
So I assume there are three very wonderful oncologists on the panel who will answer that.
Okay. Okay, Dr. Libby.
Usually recurrent infections, serious infections over and over again, and we measure the antibodies in your blood and they're low. Chemotherapy can make the antibodies in your blood low, the natural antibodies.
Okay, great. I see Dr. Medvedova nodding. Okay. And so now we know that Velcade typically makes people more susceptible to infection. We see that. I don't know if there's ever been a study on it, but we see people are posting all the time that they're more susceptible to colds, pneumonia, whatever with Velcade. And also someone mentioned that they were told by their physician that Daratumumab can also do that. Do you find that people are more susceptible to infections when on Daratumumab and Velcade?
Eva?
Yes, so I think even underlying amyloidosis predisposes patients to infection. So I think that's one of the mechanisms. Number two is all of our treatments do predispose patients to more frequent infections, but it does not mean that it always needs a patient to start on IVIG repletions. We usually reserve that for patients who have really recurrent and more serious bacterial infections, I would say.
Okay, and Dr. Lee.
Yeah, I agree. I think it's not necessarily just one particular agent from that combination. If we're thinking about any of our combinations of treatment, I think they all can cause an increased risk for infection. And like Dr. Medvedova said, just having amyloid by itself predisposes you to having, an increased risk for infections.
Okay, and let's go to our antibodies now, our anti-plasma cell antibodies, to be specific. Okay, Daratumumab being, I guess, the crown prince of that family. Okay, but then we have a few other wannabes here. Okay, we have Isatuximab and Elotuzumab, and I think there's a few others too that we don't have on the chart. So since we have you, Dr. Lee, what can you tell us about Isatuximab and Elotuzumab?
Yeah, so those are both approved in the myeloma setting. And so, like we've been talking about, we kind of extrapolate from that to apply to our amyloid patients. I don't have too much experience giving ELO in amyloid patients. Elotuzumab and Isatuximab is similar to Daratumumab, but I think, as you said, Daratumumab is kind of the first that came on the market and kind of took over and is the crown prince, as you say, Muriel. So, it's something that we kind of, stick with, and that's what's been approved in all the studies. But I will say, in general, the antibodies, the thing to watch out for is certainly, we like we just mentioned, increased risk for infection, but the risk for kind of having infusion-related reactions are the things that we talk about with patients. So it's an antibody drug that's being given. So the first time your body may see it or experience it, might have a reaction to that. So generally, the first couple doses we watch very closely during the actual treatment to see if you're having any of those side effects. And that can be as little as just like a little tickle in your throat, a cough, or it can be as severe as having kind of almost like a anaphylactic type of reaction.
Wow. Okay, so you have given patients Isatuximab and Elotuzumab both?
I have not.
You have not. Okay, are they still in clinical trials? Do you have a clinical trial involved with those drugs, or?
We don't, not for ELO or for Isatuximab in amyloid patients.
Okay, Dr. Medvedova?
Yeah, so I don't have also experience with the Elotuzumab in amyloidosis. I have used it occasionally in patients with multiple myeloma. But with the Isatuximab, we have participated in a clinical trial that prospectively studied use of Isatuximab. What we have seen is that the responses seem to be very similar to the Daratumumab. The tolerability is also very favorable. I think the big difference that is out there right now is that the Daratumumab comes as a subcutaneous injection, and the Isatuximab at this point does not. And that's a huge winner for particularly amyloidosis patients where we don't want to give them the fluids. So that's what is my typical choice outside of a trial.
Gotcha. Dr. Libby?
Same thing. We have a study with Isatuximab, or Sarclisa, I think is its name, in multiple myeloma. I have not yet used the drug, but it's generally thought to be equivalent to Dara in terms of its efficacy. The downside is that it's intravenous. It is gaining traction in the country. My understanding is that in the Kaiser, they're using exclusively Isatuximab, I think because of a cost difference. So because there's a cost difference, we may see it used more and more, but it does have some issues, like the fact that it has to be given intravenously. ELO, I've not used in amyloid. I do use it occasionally, like Eva. in multiple myeloma.
Okay, and let's ask, are there any adverse events with any of these antiplasma cell agents with kidney or heart or anything where you know there might be a warning or something for our patients, Dr. Libby?
We're really fortunate with the monoclonal antibodies, these 3 drugs we're talking about, that there is no signal that I'm familiar with in either kidneys or the heart. So these are wonderful drugs in terms of that type of side effect. The biggest issues is the allergic reactions when you first receive the drug. So that's one of the reasons they're a wonderful addition to how we treat amyloidosis.
Okay, any other comments before we move on from our antibodies there? Okay.
So one point to mention, and probably our wonderful hematologist can opine to this. I think the FDA, when they gave the approval, they slapped a warning on the Dara, saying that don't use it in patients with advanced heart disease. And in our experience, we use it in all kinds of patients, and it's an interesting balance because patients with advanced heart disease, have a lot of events because they're really, really sick. But at the same time, the light chains cause inflammation beyond deposition, beyond everything. There is acute inflammation. When you do an MRI, you actually see the inflammation. And so, using Dara with its results for the hematological response, I think does help these patients. And so I don't know if anyone has an insight why the FDA did that.
Those patients were excluded from the trial. So patients with an NT-proBNP of greater than 8,500 were excluded. So that would be my guess why they deliberately cut them out of the study.
Okay, so they were excluded, not because it might be bad for them, but just they didn't know what was going to happen. So therefore they excluded them.
Well, I think also they were worried that in terms of how do you design a trial, if you design a trial that takes the very sickest patients, then the drug may not end up succeeding because you're studying patients whose outcome is predicted to be very poor if they've got the worst of the worst for heart disease, and then you put them on the study, you may not have good outcomes. So they tried to study patients who weren't really with very, very advanced heart disease.
Right, and we'll be discussing where the reverse is true pretty soon when we discuss the CALM and the NEO-D trial. So that's very interesting. Right. Okay, now back when we started amyloidosis support groups, there was no Velcade treatment, and this chart would have looked very skimpy and meager for sure. But one thing that was on the horizon was Revlimid or lenalidomide. And people were still using thalidomide at that point too. And pomalidomide was just kind of a future dream, I guess. So, and people we see are they're still using Revlimid with some success. So let's discuss Revlimid and all the good, the bad, and the ugly that goes with it. And Dr. Libby, since you're on screen, why don't we take you and what do you have to say about Revlimid or lenalidomide?
Well, in general, it's not recommended to be used for newly diagnosed patients with amyloidosis because it can exacerbate or worsen heart function. It can increase your BNP, and patients who don't tolerate it well. It also has to be adjusted for renal function, which doesn't mean it shouldn't be used in people with abnormal renal function, but you have to be really thoughtful about it. So generally, for a variety of reasons, patients don't tolerate it. Many patients with amyloid, and it's not recommended to give Revlimid to newly diagnosed patients. If a patient doesn't have cardiac problems, I feel a lot more confident using it. But again, like carfilzomib, you've got to be thoughtful and be sure you know what the status of their heart is before you give Revlimid. I have used it in amyloidosis when CyBorD doesn't work, or when, believe it or not, daratumumab, it's not that uncommon that it doesn't work. It's a great drug, but it's not perfect. And so I do use Revlimid in patients when the better drugs are not working, but with caution, especially in people with heart disease.
Okay, and Dr. Medvedova.
Yes, so Revlimid does require dose adjustments. I think it also needs to be used in caution in patients with renal dysfunction and nephrotic syndrome. There have been some signals that the kidney function did get worse with the Revlimid.
Good point.
Well, pomalidomide might be somewhat better tolerated drug in the AL amyloidosis population. There, I think the major concern are lower blood counts rather than the signal in the heart or kidney dysfunction.
Okay, Dr. Lee?
Yeah, I agree. I think, definitely not in the first round of treatment. And then as we get into second, third, fourth lines, we experience this, right? Where it gets tricky about which drugs to pick, which combinations, and balancing the side effects. And we don't have the great, the luxury of having all the data that we do in multiple myeloma. So it becomes a little bit tricky, but yeah, agree with Dr. Medvedova and Dr. Libby.
Right. Well, we know that, for instance, Velcade can make one susceptible to shingles. So people are put on anti-shingle type drugs. And for some reason, Revlimid and its family of drugs makes one more prone to blood clots. So usually people are on blood thinners or aspirin. Can you go into that a little bit?
I think you stated it really well, Muriel. Yeah, both thalidomide, Revlimid, and Pomalyst or pomalidomide, they all increase the risk for blood clots significantly. And you need to be on, especially when you combine them with steroids or with some other drug, you need to be on at least on an aspirin. If you have risks for more serious blood clots, like risk for stroke or risk for heart attack, say you have high cholesterol, high blood pressure, you're a smoker, and you have amyloid, then you have to consider using something more powerful than aspirin.
You're in trouble then, aren't you?
You're in trouble. And you need something more powerful than aspirin because these drugs, Revlimid, Pomalyst, can also cause heart attacks and strokes.
All right, well, let's go. That's a good segue over to Dr. Masri and Dr. Cheng. So Dr. Masri, let's hear from you on that.
Yeah, I agree with everyone have said. They are being used, not very commonly. We have a couple of patients that, are doing very well on them. We have had some instances where you have to titrate the diuretics a little bit more because they do increase a little bit, how the patients are feeling that they had some heart failure. One interesting side effects that actually does not lead to more symptoms, but makes the patient worry is the elevation in NT-proBNP. So they can actually elevate NT-proBNP without worsening heart failure. And so sometimes we get these calls from patients who are scared saying, oh, my NT-proBNP is going up, but I just feel fine and everything's fine. And typically that's just because of them. And this was published on before. There are 1 or 2 papers who looked at the NT-proBNP elevation. And so thankfully, we haven't actually had any events because of the practice, how you alluded to, using either antiplatelets, antithrombotics. We haven't had strokes or MIs so far, thankfully.
Great. Dr. Cheng?
Yeah, no, I kind of echo what everyone else has already said. I don't have much additional to say. I mean, I've seen some patients be on this long-term for maintenance, and thankfully I haven't seen many side effects from it because I think we know and recognize what the side effects are and are very cautious in preventing them.
Okay, and Dr. Malik, some kidney toxicity was mentioned with Revlimid. Have you seen that?
So I would say that in the vast array of all the treatment regimens that are available in myeloma and amyloidosis, I think the biggest caution and concern comes with Revlimid. And so the hematologists already are very keenly aware of that. And I think, as Dr. Libby and Dr. Medvedova are saying, they usually really choose this drug way down the line and when they really need to. But yes, in literature, it's been quoted that it can lead to some kidney dysfunction. I don't think we exactly know the mechanism, how that happens, but yes, there is some caution and dose adjustment that's needed with kidney dysfunction.
Okay, it was mentioned briefly by, I think it was Dr. Cheng, about he has seen Revlimid used on maintenance, and we have seen that people post about being on, even though we know in AL amyloidosis maintenance is not something that was used a lot until Dara-CyBorD came along. And then now we see people on Dara-CyBorD for quite a while. And I don't know if you'd consider that maintenance or people just don't know when to stop. But we're also seeing Revlimid in very small, 5-10 milligrams being used as maintenance. So let's hit with Dr. Libby and go on the maintenance binge a little bit with Revlimid.
Well, it's a big question in amyloidosis is should patients get some sort of long-term treatment? You get your initial treatment for 6 months, for instance, or you get a little bit of treatment in a stem cell transplant. Should we treat you in a fashion similar to multiple myeloma? The standard in multiple myeloma is that patients are always on something. Your continuous treatment, you're never off of treatment in multiple myeloma. So many oncologists, hematologists have transferred that approach. They think in the same manner when they see an amyloid patient and they put you on maintenance. But there's no data, there's no research to support maintenance. And so the majority of amyloid treaters have not given maintenance up until very recently. But you will see patients who are put on Revlimid long-term. And that's the standard in multiple myeloma is you're on usually 10 milligrams of Revlimid. The standard dose is 25, so you're on a small dose of Revlimid without steroids, and you take it forever. You take it as long as it works. In general, that's not what's recommended in amyloidosis. This new study, Dara-CyBorD plus CyBorD or VCD, they administered maintenance for 2 years. And the reasoning behind that, I'm not entirely sure. But because that is evidence-based, it's a well-done trial, that is going to become the new standard is that patients receive Dara-CyBorD and Revlimid, I believe, for 2 years. I'm sorry, not Revlimid, VCD. You get the VCD for 6 months, and then you get Dara-CyBorD maintenance for 2 years. So that's the new standard.
So VCD
is the same as CyBorD, really.
Right.
Yeah.
Okay. And Dr. Lee, what do you have to say?
Yeah, I think it's the same. I think that's something that we discuss a lot in our own group at SCCA about maintenance now in patients with amyloid, because like Dr. Libby said, it's not something that generally has been standard practice. Certainly in myeloma, yes, but not in amyloid. But like you said, now with this new study that, with Dara-CyBorD introducing the concept of maintenance for 2 years of Dara-CyBorD, we're starting to kind of shift our thought to doing that.
Dr. Medvedova?
I do agree. I mean, I don't want to open the can of worms and talk about the myeloma amyloid overlap, but I mean, that's sometimes when the patients also meet the diagnosis of multiple myeloma at the time of diagnosis. So those were the patients that we have historically considered candidates for maintenance.
Well, why don't we we'll kind of skip past what we were going to do on our agenda and go to the multiple myeloma overlap while we have you, because, we have so many patients that come to us. I've got multiple myeloma and amyloidosis, and they don't really have multiple myeloma. They have 10% plasma cells or more, and that gives them a diagnosis of multiple myeloma, which is good and helpful. Paula just explained to us that if you have multiple myeloma, you get $11,000 from the Leukemia Lymphoma Society, along with your diagnosis of amyloidosis. And if you have 8% plasma cells, you miss out on $11,000. So that's right there, a nice reason to have that diagnosis if you can get it. So let's discuss the overlap, when it's real, when it's not, and how many actually have, what percentage of amyloidosis patients actually have multiple myeloma?
Well, I think the definitions differ. And so I think that's one of the really problems, how to define how many patients do have the overlap diagnosis. I think probably the established 10 to 20%, I don't know, Dr. Libby may be a little bit more knowledgeable about the exact numbers there. But many times what we are finding now, particularly in the era of the new myeloma diagnostic criteria, where light chains alone without symptoms of multiple myeloma that include anemia, kidney dysfunction due to the light chains, bone disease, give you the diagnosis. So it's kind of shifting. So I don't think, again, we know the exact numbers. I think one of the things you said that sometimes it can be helpful, it is when we can easier get the treatments for myeloma when we put this label on.
Right, because all of the treatments except for daratumumab are only approved for multiple myeloma, not amyloidosis. But if you can add that diagnosis of multiple myeloma on there, the insurance companies will not argue about getting those treatments. And that's another plus for having that diagnosis. And Dr. Libby, what's your take on this?
Well, I tend to think a lot about this question and worry about it maybe unnecessarily, but if you're diagnosed with multiple myeloma, your treatment is different and your prognosis is different than if you're diagnosed with pure amyloid. And so if you receive the diagnosis of multiple myeloma, then you're in a category where you must receive a transplant if possible. You should be on therapy for the rest of your life continuously. Whereas with amyloidosis, we don't believe that particularly being on therapy all the time for the rest of your life, we don't believe that's true. And I personally don't believe it's true. So it is important to know, do you truly have multiple myeloma and require all the extra therapy, the much more intense therapy that a myeloma patient requires, as opposed to being pure amyloidosis? You need less therapy. You can be treated much more conservatively. And that's where I think seeing an amyloid doctor can make that's one of the areas that seeing an amyloidosis center can make a big difference, because you could be overtreated if you're mistakenly diagnosed with multiple myeloma. And what you really have is just, you have pure amyloid. There are, like Eva said, sorry to interrupt, Neryl, there are these overlap patients that are in between. You're not quite sure, is this myeloma or amyloid or both? Then you're going to probably err on the side of, well, I'm going to have to pretend that it's myeloma, because I don't want to be wrong. I don't want the disease to come back sooner and cause terrible problems.
And that brings up something that patients often ask. They'll say, I have AL amyloidosis secondary to multiple myeloma. And the Mayo Clinic has said, AL amyloidosis is never a secondary disease, nor is multiple myeloma. So they're both major primary diseases. So when someone has the diagnosis but also the Mayo Clinic says that if you have a high percentage of plasma cells, 10% or more, you're more difficult to treat than the average just AL amyloidosis patient, and there possibly is worse outcomes for you. So let's take all of our hematologists on that one. Dr. Libby?
Well, I don't think I think it's much more sophisticated, much more complex than just, okay, you're 10%, you're 10.1%, now you have myeloma and you need treatment for the rest of your life. I think I'm sure anyone would agree with me, but there's a lot of subtlety to this that we don't understand yet. So if we looked genetically at amyloid patients, their plasma cells in, say, somebody with standard amyloid tend to actually look differently genetically than a multiple myeloma patient. And that's why their plasma cells don't behave the same way. They don't break bones. They don't cause hypercalcemia in the vast majority of people. So I think yes, if somebody has a lot more plasma cells, it's something to consider. But I don't think I think it's arbitrary to choose 10% or 20% or even 30%. It's much more individualized than that. And we will be unraveling this mystery over time, but right now it's a simple answer has been, if you have 15% plasma cells, that's too much for amyloid. We need to kind of think of you a little bit more as a myeloma patient. I sort of agree with that.
Even if someone has severe cardiac involvement in their amyloid, and some of these drugs that you would want to do for maintenance for multiple myeloma might be toxic to the heart?
Well, absolutely. It would be hard to treat somebody with bad cardiac amyloid and who has myeloma as well. It'd be hard to use some of the myeloma treatments like Revlimid. Yes.
And Dr. Lee, what do you have to say about that?
Yeah, I think it's very nuanced, I think is kind of the final, I think the overarching theme is that it is important. That's why it's important to really seek out an amyloid expert or someone who can really kind of tease out the finer details of things. Because like you said, you could have, maybe 15%, but you have all this cardiac involvement. So likely it is more amyloid than myeloma. And same, if you meet the criteria of having 10% plasma cells and renal failure, you would say you're a myeloma, but that renal failure could all be, from amyloid. And so it's those things I think that, it's very nuanced. It's not just straightforward kind of going through a checklist of you have this, you have this, you have this. Okay, you have myeloma. Okay, you have amyloid.
I want to get to Dr. Medvedova for a second, but first I want to ask Dr. Malik, because Dr. Lee, you brought up a very interesting point. Dr. Malik, we know that when you have real myeloma, one of the conditions from it is renal problems. We all know that amyloid can cause renal problems with the filtering system. What is the difference between the renal problems from myeloma versus the renal problems from AL amyloidosis?
Yeah, they are very distinct. And we obviously need a kidney biopsy to get to that, because both disease processes present completely differently in the kidneys. With amyloidosis, you get a pretty uniform kidney pathology that we see on the biopsy. But with multiple myeloma, you can have at least 4, 5, 6 different kinds of problems that can happen in the kidneys. And to some extent, it also depends on the quantity of the light chains, or how extensive the light chain burden is in the body. That can present with more rapid kidney failure and multiple myeloma, with blocking of the kidney tubes and whatnot. But there are more subtle changes that can happen in the kidneys from smaller quantities of light chains. We sometimes see in MGUS or smoldering myeloma patients a full-blown kidney failure. So you don't have to have a very extensive, large tumor burden to cause myeloma-related kidney problems. You can have a small tumor burden, yet the light chain is toxic enough that it can give rise to 4, 5, 6 different kinds of presentations in the kidneys. But those are all very well recognized that they go along with the multiple myeloma family of kidney problems. When it comes to amyloidosis, yes, it's an entirely different presentation. And so you can very easily distinguish between the two on a kidney biopsy.
Okay, thank you. Dr. Medvedova, do you have anything to throw in here?
Not too much to add to what Dr. Libby and Dr. Lee have said, but one of the, I think, interesting points is that the Andromeda study, to my memory, has excluded patients only based on the revised myeloma definition, and not said that patients have a myeloma if they would have had 10% plasma cells. So I think that could be informative how we can approach the patients.
Okay, well, we'd like to keep that 10% definition for our AL amyloidosis patients, so they'll have access to the treatments, and so they'll have access to $11,000 from the Leukemia Lymphoma Society. So if there's any way you could kind of word it that way, it'll help. Okay, now let's go to another family of drugs right now, okay? And we'll go back to the antibody trial, but we're not talking about antibodies that go to the plasma cell. We're going to talk about the antibodies that go to the organs themselves and attach themselves to the amyloid fibrils and vacuum them away. Now, we know that we had the NEOD trial, which failed. But then after they took a second look at it, they said, wait a minute, people with really bad cardiac issues seemed to improve. So now they've come back and they're doing a whole new trial with people with, with more severe cardiac issues. And now we have Calum that's going to be, that has their trial, that's already had their trial. And it's still going on for newly diagnosed patients with cardiac issues. Not quite as severe as the NEOD trial is going to be looking at, but pretty severe cardiac issues. So what we'll need is for our patients, we want to know, do we have an update on what's going on with Calum and NeoD, or NeoD's new name? It's not a new name, I guess, but it's a new name to all of us. Maybe they're trying to get rid of the stigma of the NeoD name, so they're going with the new name. But why don't you give us an update as far as you know, Dr. Medvedova, and then we'll go to our other physicians as well.
You're right. So the Calum has now 2 studies that are very similar in design open. They are all for patients who have newly diagnosed amyloidosis, and they have to be of advanced stage. So they are taking patients with a stage 3A and stage 3B cardiac amyloidosis. And the study has opened to accrual at this point. As for the NeoD study, so that one is also, I don't know if it's open to accrual, but certainly very close to that. And that is now based on the experience from the VITAL study. They have, they're specifically targeting patients with the most advanced cardiac amyloidosis only and newly diagnosed. So unfortunately, no patients who have previously been treated for amyloidosis would be eligible for any of these trials.
Okay, do you have, do you have the Calum trial at your place?
Yes, we do have the Calum trials open at our place.
Okay, and do you plan on having the NeoD trial when it opens?
We are considering that.
Okay. And Dr. Libby, what about you?
We have the 2 Calum trials open. We've recruited at least 1 person into the trial, and we're not going to open the NeoD. We thought Calum will keep us busy for a while.
Okay, and Dr. Lee, since you work with Dr. Libby, but do you have anything to add to that?
Yeah, I will say one thing about the Calum trials right now is that the initial treatment is with the, it's a double-blinded randomized study, so you may or may not get the treatment drug, but the backbone is CyBorD and not Dara-CyBorD, so I think that's important to note. But we do have the option after 2 cycles, if the response, the hematologic response is not what we would expect to, physician's choice to kind of add in Dara if we want to. So that is a slight difference from what is standard now with Dara-CyBorD. On the trial, you would get CyBorD plus or minus the drug, but with the option to add in Dara after a couple cycles.
Right. We did discuss at one of our previous webinars, and folks, you can go click on our webinar link and on the website and see it. We did discuss the NeoD drug making an appearance, and that is going to include Dara as well as CyBorD for newly diagnosed treatment naive patients. Now, but Calum had mentioned at one of our webinars that they were thinking of opening a trial for previously treated patients. Do we have any news on that? Dr. Lee, are you aware of anything?
I know that we've had some meetings with some other sites and with the cooperative groups thinking about Calum in people who have particularly renal failure still from amyloid, but I think it's still a ways away, but trying to look at people, who maybe not in the newly diagnosed stage, but people who've had a good hematologic response, but continue to have organ dysfunction because of their amyloid. And so just to, I don't know if we really have talked about it yet, but why we're so excited about drugs like Calum or NeoD is that, the treatments that we have now that are the myeloma drugs that we've all talked about really target the plasma cell and the production of light chains and amyloid. But these new antibodies are targeting the amyloid protein that's already deposited in the organs. And so you're kind of working twofold, one to prevent the production of any more amyloid, but to now potentially the ability to kind of clean up the amyloid that's already there and to try to improve organ function.
Right, thank you. That's absolutely great. And Dr. Libby, do you have anything you want to add to the NeoD Calum thing?
No, I think I agree with everything that's been said. Very exciting stuff.
Okay, super. And Dr. Medvedova?
I believe that the Calum study also is considering the addition of daratumumab upfront to the CyBorD as one of their amendments in the protocol as well.
Is Dr. Wall in on this? Dr. Wall, are you with us right now? I know.
I am here, Muriel, yes.
Okay, yeah, oh, I can see your dragon. Okay, Dr. Wall, did I not read recently that you are working on some NeoD-like, Calum-like drug that will remove the amyloid from organs, or am I making this up?
You're not making it up, Muriel. Yes, we're working on, in collaboration with the trialists, working on some other agents that specifically target amyloid and will hopefully affect their removal.
Now, I'm a little confused, and I confuse easily, because I thought that the University of Tennessee, where you do your wonderful research and studies, I thought that you were kind of the birthplace of the Calum drug.
Yes, that's correct. Yeah, we originally developed the antibody, and then we did a first-in-man imaging study with the antibody, and then Calum took it over to do the phase 2 trial.
So you kind of gave it up, and now you want to be in control again, so you're starting your own again?
No, I don't any control whatsoever. We're always in the lab trying to work out ways to diagnose and treat amyloid and come up with new ways to do it.
So the imaging and it's going to be exciting, because hopefully what you'll see, kind of like what they were doing in the UK, you can see the before, and assuming these drugs work, the Calum, the NeoD, and your new guy that you're going to be working on, and then you can see the after, and you'll see it all disappear, right? In a perfect world?
In a perfect world, that's the goal, yes, to be able to watch the amyloid disappear.
Okay, great. We'll be back to you in a minute. We're going to discuss stem cell transplants, and then we'll be back so you can give us an update on your imaging study. Thanks so much. We love your wallpaper, by the way. Thank you.
Thanks, Muriel.
Okay, so let's go back to stem cell transplants, folks, okay? Because that's kind of the elephant in the room, because we all know that that was the standard of care for many years. And then it sort of, with Velcade, it kind of took a little back seat, not at the Mayo Clinic, where it was always the #1 priority, if you were one of the 20% that met the criteria. And now we're seeing the Daratumumab and CyBorD. And so what's your opinion of stem cell transplants? Where do they fit in for our amyloidosis patients? And we'll start with you, Dr. Libby.
Well, it's evolving. There's at least 2 studies out now that suggest that using modern therapy, and these studies would be CyBorD and or Revlimid or some of the other drugs that we've mentioned, that you can achieve results that are very similar to those achieved with stem cell transplant without getting a transplant. So Mayo has published one, and Indianapolis has published one, and there may be others or other abstracts out there. So, and that's always been a thought-provoking for me, because transplant is a harsh therapy. Yes, it's quite effective against the plasma cell. We know that. It was one of our best first ways to kill plasma cells, and that's what we want to get rid of in amyloidosis. But it can be quite toxic, and in amyloid patients, there is an increased chance of poor outcomes and even dying from a stem cell transplant. So I personally am very excited about using non-transplant approaches to treat amyloid patients. As you've said, we first of all have to remember that only 20 to at most 30% of patients are eligible for a transplant when they're diagnosed with amyloid, and that's because you're too sick. Most patients, the majority of patients, have cardiac and renal dysfunction, cardiac and or renal dysfunction when they're diagnosed. And if you have particularly cardiac problems, heart problems, you're not a good candidate for a transplant. So in the majority of patients, transplant's not an option anyway. But it can have very long progression-free survival and improved survival based on older studies. So I think it's still a good treatment for the right patient who doesn't have any heart issues and and whose kidneys are in fairly good shape. It's still a good treatment, but I'm very enthusiastic about using CyBorD Dara and perhaps avoiding transplant in a significant number of patients.
Thank you. Dr. Medvedova?
I agree with everything what Dr. Libby has said. To add to it is, we obviously have the long-term data from the stem cell transplant that at this point we do not have from the non-transplant therapies. but I would certainly love to see the transplant go away in the amyloidosis population particularly. And that the selection of the patients is really critical, and the transplant is not for everyone, particularly in the amyloidosis world.
Okay, and Dr. Lee.
Yeah, I couldn't agree with either of them more. And I was thinking the same thing that Dr. Medvedova just said. It really is about patient selection. So picking the right person to even offer it to, and even if we need it now with these new therapies. So
I would say one thing about transplant and amyloid that I was taught when I was a visiting fellow up here many years ago, and Tom Chauncey taught me this, one of our transplanters here, and he told me I was going to go start a small transplant program in New Mexico, and he told me, do not do transplant. You're going to have a small transplant program. Don't transplant amyloid patients. Don't do it. Let the big centers do it, because there's a lot more problems. The side effects and the mortality is higher. You don't want to do it in a small center. And I didn't. And I think I would recommend to a patient with amyloid who's going to get a transplant, get it in a large center. You don't want to do it in a small center that's only doing 30 to 50 transplants a year. You want to be in a big academic center who has a lot of experience with this, because things can get hairy quickly with a stem cell transplant and amyloid.
Okay, great, thank you. I certainly understand the long-term data, because we know that there are people that have had stem cell transplants and are 10, 15, 20 plus years or more without ever needing another treatment and have a nice normal quality of life, hopefully forever, but we don't really know if that's true. And we don't have data like that yet for Dara-CyBorD, and won't have that for quite a few years, and Fibril as well. So we certainly appreciate your input on that. And now we're going to discuss, we're going to have Dr. Johnathan Wall from the University of Tennessee discuss his imaging trial, the data that he's had so far with it. I know some of our patients from the Pacific Northwest have even flown to Tennessee for this. And so Dr. Wall, we're ready for you.
Right, you are. Let me start this up.
How many patients have you seen so far, with all types of amyloidosis? How many have you imaged so far?
We've imaged 48 with all type, with as many types as we can find, yes.
And how many AL?
19 ALs and 1 repeat scan in an AL patient.
Why did you do the repeat?
Sorry?
Why did you do a repeat?
So we have well, for the same reason that you were mentioning it, we think there's a lot of value in being able to demonstrate response to therapy or progression of disease in these patients. And so we have a cohort where if you had a positive uptake in the initial scan, then you're eligible to come back and get a second scan.
Gotcha. Well, take it away.
So thanks, Muriel, again for the invite to talk about this. So I'm going to talk about this peptide that we've developed at UT Medical Center, and it's also called AT01, but we call it P5+14 originally. And we've developed it for the evaluation of systemic amyloid in all types of amyloid, but I'll just talk about AL mostly today. So as a disclosure, we have funding. I'm a scientific founder of a company, interim CSO of that company, and we have patent rights in it. And I will say that I will interpret the images, but I'm not a radiologist, and the data are still unpublished, and this is an experimental procedure. So if I'm wrong, I have all the patients as you come in during the pandemic. In fact, last year we imaged more patients than we did the year before. A remarkable, engaged group of people, and we couldn't do what we do without their support. So we all know that light chain amyloidosis is formed from light chains, which are part of normally antibodies, and they're produced by plasma cells in the bone marrow, and the light chains enter the circulation, and we know all about this part of the pathway. And then there's this sort of magical process that occurs where the light chain misfolds, wants to form amyloid, and then does form amyloid. And this is the tricky part, is actually appreciating where the amyloid forms throughout the body. The first we actually know about it is when the organs lose function and you seek medical advice, and then we appreciate then where the amyloid might be, but we don't get a full picture of it even at that point. And so light chain amyloid is a multi-organ disorder. Predominantly, maybe one or two organs might be involved or might be causing the problems. Generally, the heart and the kidney are associated with that, but amyloid in the AL in the liver, the spleen, the intestines, the nerve, lymph nodes, pancreas, bone marrow, any organ or system can be involved in AL, and often is. And again, our goal was to try and understand what the full picture of amyloid looks like in patients with this very complex disease. So we started a first-in-human imaging study at the medical center, and to date, it's been supported by donations from the researchers and patients, again, which we're very grateful for. So the agent we've developed is a small peptide, which is a small protein, and it's very positively charged on one face of the peptide. And we put a radioactive tag on it so we can image it by PET imaging, which is a standard clinical imaging modality. And the reason it works is because amyloid, represented by the fibril sort of in the green, and a lot of the accessory molecules that are in amyloid deposits, and there are a lot of them, are very negatively charged. And the reason we can get specific binding and imaging of the amyloid is because the positive charges on the peptide bind to the negative charges on the amyloid very specifically. And if that interaction is strong enough, the peptide will stay on the amyloid, and then we can image it. As we mentioned, this is the scope of the trial as it started. The first patient was enrolled in November of 2018. And the first 3 patients we did all had AL amyloidosis. They were part of part 1, which is obviously completed. And we did those 3 patients to estimate the radiation dose that was associated with this injection, and to watch. We imaged these patients serially across 48 hours to watch how the radioactivity changed in these patients, and I'll show you some of those images. We're well into part 2 of the study right now, which is 85 patients, and they're broken down into these categories. One of the things this peptide does, or did in the lab certainly, was had the ability to bind to all types of amyloid. So one of the goals of this trial is to demonstrate that in patients with multiple different forms of amyloid could benefit from imaging. But so far we've got 19 patients imaged with AL, and I think we have another 12 or 11 or so already booked, ready to go. 20 patients with TTR amyloid, and we've almost finished that cohort. ALEC2 is a rarer form of amyloidosis, 3rd most common in the US. We've imaged 2 of those, and and some rare forms, a localized AL amyloid, lysozyme, gelsolin, ApoA1. And something we hadn't done in the last talk, Muriel, was we've actually done 4 healthy subjects now, so we know what normal looks like. And then we've got this ability to repeat image patients who had a positive scan. We generally give a low dose of the peptide to each subject, and a very low dose of radioactivity, just sufficient to image. And we image the patients about 5 hours after we do the injection. And the study is it's a phase 1/2 study now, and it was designed to assess the safety of the reagent and determine whether we can image organs that were known or suspected clinically of having amyloid. So that was the goal of the study. If a patient was recruited and they were told they had hepatic or cardiac amyloid or renal amyloid, then the goal of the study was for us to be able to image that organ specifically. And everything else we learned was also great in addition to that. So this is a healthy control, a healthy subject, no evidence of disease at all. And what I'm showing on the left here is what we call a maximum intensity projection. It's just a flat image of that patient. So the image is sort of 2D. And there's quite a lot of signal. So the black is where the radioactivity is, and this is what we consider to be normal. Every patient we see, and including the healthy subjects, have this sort of distribution. And what happens is, so the peptide's radioactive, and if there's no amyloid to bind to, it gets cleared by the kidneys. And 2 things can happen at that point. It can either go into the bladder, the urinary bladder, as a radioactive peptide, so you can see radioactivity in the bladder. And you can also see sort of radioactivity in the urine, in the kidneys, and passing down the ureter, which is the tube that goes from the kidneys to the bladder. But something else can also happen in the kidney. So some of the radioactivity can be stripped off by enzymes that live in the kidneys, and that radioactivity re-enters the circulation and gets picked up by the stomach and enters the sort of the lumen of the stomach and is eventually passed out. And then some goes to the salivary glands and glands in the neck called the parotid glands. And because of that, you make radioactive saliva. And as you swallow the saliva, this is what this is. This is the saliva going into the stomach. You get these sort of hot spots in the esophagus. And then you'll get some radioactivity in the thyroid, but a lot less than everywhere else. So this is what normal looks like. And if you look at sort of one of the 3D images, this one shows the heart and the liver. You can see there's absolutely no radioactivity at 5 hours post-injection in the heart or the liver or anywhere else. This is a slice of the stomach. And again, if you look at the heart on the axial slice, this is where we would normally see in amyloid patients. You see this classic horseshoe accumulation of amyloid in the left side of the heart, which is has the thickest muscle, so it accumulates the most amyloid. But you can see in this image, there's absolutely no radioactivity, no color at all. And I show that because I'll show you some amyloid patients now. So this is 2 of the first 3 patients, and these are patients that we scanned multiple times over 48 hours just to know what happens when we inject the radio tracer. So the top patient is a patient who was diagnosed with mild cardiac amyloidosis and renal involvement. So within 25 minutes of the injection, you can see all the black is the radioactivity, and it's in both kidneys. This is the liver, and you can see some heart, and then again, you can see these glands in the neck. But as we wait across time, you can see that the radioactivity is lost from the liver, but it's retained by the kidneys and retained by the heart. And then you can also see some activity associated with the lungs in this patient. And by the time we image at 6 hours, which is 5 to 6 hours, which is when we image the patients now, you can see the left side of the heart is lit up. This is the stomach. You can see some retention in both kidneys, and you can see some uptake in the walls of the lung as well. And so when you look at the patient in the bottom row, another classic pattern of amyloid, this patient had very extensive amyloid in both kidneys and the spleen. And within 25 minutes, both the kidneys and the spleen were easily visualized. At 50 minutes, you can also see the pancreas light up in this patient because of the amyloid there. And those 4 sites, both kidneys, the pancreas, and the spleen, stayed positive for well into 48 hours because this patient had a lot more amyloid than the patient in the top. But where there is no amyloid, those organs clear up, and certainly by 6 hours or 5 or 6 hours post-injection, we're able to differentiate a normal organ from an organ that has amyloid. Here's a classic example, patterns of amyloid in AL patients that we've seen. This really speaks to the fact that if you've seen one AL patient, you've seen one AL patient. I think that's something we can appreciate now by imaging. So 4 different patients on the top row. These are the black and white flat images. In patient 1, you can see bone marrow involvement, which is severe amyloid bone marrow involvement, which is common in some amyloid patients. Both kidneys, the liver in this patient was the organ that was used to diagnose the disease based on a liver biopsy. But the spleen is also positive, and the heart is positive as well. In patient 10, P10, you can see even more extensive bone marrow involvement of the amyloid, massive accumulation of amyloid in all the organs, liver, spleen, kidneys. And you can see the bone marrow in the spine as well as a shadow on the heart. In patient 16, no involvement of the liver, very little in the spleen, but both kidneys, extremely high retention of the imaging agent, suggesting a lot of amyloid, and both the left side of the heart and the right side of the heart are lighting up. And in patient 17, again, only the heart lit up. There was no involvement in any of the other tissues. This area below the heart is the stomach, but the left side of the heart is exceptional, as is the right. So each patient is different, and the amount of amyloid they have is different. But there's normally always one major organ. And when you look at the bottom row, these are the same patients. And the nice thing about the PET-CT imaging we do, it generates 3-dimensional images, which we can sort of manipulate and look at these organs much more specifically. And you can see the heart involvement in a lot of these patients, the liver and the pancreas, the spleen, both kidneys, But you really get to appreciate the distribution and the amount of amyloid that you see in these organs throughout the patient. This is a study of, just to show a little bit more detail about patient 7. Again, this is the patient that was diagnosed based on a liver biopsy, and you can see the whiter or the red of the colors, the more radioactivity there is there. So the liver, which is this area here, is very bright, heavily involved with amyloid. But also this area here is the pancreas. He had pancreatic, which we assume is pancreatic AL, but also the heart, which was clinically silent. So there was no evidence in this patient of cardiac amyloid, but it was present. And if you look at the slices of image, so these are now slices across the body, the liver's obvious, the pancreas is obvious, and now the spleen. The spleen is an organ in AL patients that's very difficult to detect the presence of amyloid because there are no blood biomarkers that you can test that pop up early in the deposition process, but it's quite commonly seen in AL patients by imaging. If you look at the heart, here you can see the characteristic horseshoe that I was talking about, characteristic of amyloid associated with the left side of the heart, which is the thick one. And then you can see positive but sort of weak radioactivity in the liver. So one of the things you can appreciate with the agent, I think, is that we can estimate how much amyloid there is in every organ that we can actually see. And in this patient, the liver and spleen are remarkably involved, less so in the heart, and even less so, but positive in both kidneys. In this patient, again, completely different pattern of distribution. And I say this one because we're actually seeing radioactivity in the pleura, which is the sort of line of the edge of the lungs, as well as this, again, weaker but still positive uptake in the left ventricular wall. And this is the septum that divides the left and right side of the heart, which is very positive relative to the outer left ventricular wall. Again, what's remarkable to us is the variety of the deposits in these patients. This is the patient that had the worst cardiac function based on serum NT-proBNP, which is an enzyme generated by the heart when it's not functioning correctly. But it can also be influenced by many other things. This patient didn't have significantly more amyloid in the heart relative to the other patients, obviously had a very enlarged heart, but this patient also had extreme kidney involvement. And that combination, heart and kidney, resulted in really poor kidney function. The patient was on diuretics, and those combinations can cause a massive elevation of NT-proBNP in the blood. And this patient, I think, had a level of about 17,000. This is a good example of being able to see the left and right side of the heart involved with amyloid. This is again that patient, just to focus more on the kidneys. You can see both kidneys are very red, indicating massive amounts of amyloid, but the liver and spleen in this patient have no involvement whatsoever. Although it's difficult in these patients using this agent to say anything truly definitive about radioactivity in the mouth because of the radioactive saliva, the radiologist, who's way smarter than I am, said that because of the distribution he was seeing around the tongue, he was fairly confident that this might be the presence of amyloid in the tongue, which again is seen in AL patients. It's not that common, but it is a manifestation that becomes apparent. This is one of the first patients we imaged, and what was remarkable about this was the uptake of the radiotracer in the pancreas. We've seen that in a few AL patients, some TTR patients, and some patients with the rare forms. It's not related to their diabetic state. Patients with type 2 diabetes can often have, or always have, amyloid in their pancreas, but it's very small amounts. So I think it's fairly unappreciated that patients with lots of amyloid in other organs can get infiltration of the pancreas, which is this sort of line here. These are both kidneys, left and right kidneys. And again, you can see the liver, there's no involvement whatsoever. But this patient did also have a very high accumulation in the spleen. As part of the demonstration that we can see lots of different types of amyloid, here's a panel of patients with other variants of amyloid. So TTR, ALEC2, a couple of patients we've imaged with that. Gelsolin amyloid is an amyloid that impacts the nerves and the GI tract mostly. But it's also present in very high concentrations in the kidney, and quite remarkably doesn't cause any problems in kidney function, despite the fact there's massive amounts of amyloid there. Lysozyme is a very rare genetic form of amyloidosis. And in this patient had massive spleen involvement and both kidneys as well as other organs, including the liver and including the heart and the pancreas. So because all amyloids contain fibrils and they all contain these accessory molecules, this peptide is able to bind and image all types of amyloid using the same mechanism. It's this charge-charge interaction that we're able to exploit. So what can amyloid imaging tell us? And we didn't set out to prove the clinical value of this imaging agent. We just wanted to show that it works. But along the way, we've encountered some very interesting patient stories, and I'll just show you a couple of these. So this is the patient that had probably the most extensive AL amyloid deposits, a young lady who's done exceptionally well following a kidney transplant. She was diagnosed based on kidney involvement about 8 years ago. And you can see there's huge deposits in the organs, in the liver, spleen, and kidney sort of organs in the abdomen. And then there's also the heart. You can see the bone marrow. But what was remarkable about this patient was that the amyloid had extended also to 2 organs that are outside the brain, but associated with the brain, the choroid plexus and the pituitary. Both are known in the papers that we read to contain amyloid, but we were able to image that in this patient. It's a rare observation in the patients we've looked at, but it was present. And then what I want to show you is this story here. So she had a kidney transplant because of renal failure due to amyloidosis. And so we were able to image the 2 kidneys, original kidneys that were full of amyloid. So this is the liver on the left, spleen on the right, and then this sort of little arc here is the right kidney, and then shriveled left kidney. But then we evaluated her transplanted kidney, which was transplanted to the pelvis, and there's actually no uptake whatsoever, which was a great story. And even though she hadn't come to check out her new kidney for the imaging, we were able to demonstrate that there was no amyloid in the transplanted kidney at the time of the imaging that we did, but both other kidneys were very positive. So it was a great story. This is another patient that was diagnosed with kidney amyloid many years ago, had a stem cell transplant, 1 round of chemotherapy, responded exceptionally well, became the poster child for doing well after that type of therapy at Vanderbilt Medical Center, and still had poor renal function with respect to EGFR, which is a measure of how well you're filtering everything. So we were expecting to see kidney uptake. On imaging, though, all we saw was blood pool. So that on the left, we see the axial slice of the heart and the liver, and the light blue is just blood pool. In the middle, you can just see the stomach radioactivity, and on the right, you can see both kidneys with absolutely no amyloid left in them at all. So it's a well-known phenomenon that patients with AL who respond exceptionally well and go into either very good or complete remission, the amyloid deposits can resolve themselves by mechanisms we don't understand fully yet. But this was an example of that kind of patient where essentially she looks exactly like a healthy subject with no uptake in any organ whatsoever and just a sort of normal radioactivity background that we would expect. So again, another good story. Didn't do much for our statistics on the trial, but it was a good story. So what can we add to the clinical picture of these patients? So here I've just summarized what the clinicians know of, so what we've pulled from the medical record about these patients and what we can actually image. And a 2 is a very positive determination of the disease being present in these 4 organs. A 1 is a maybe, and then a 0 is absolutely negative. So in the heart, the clinicians know when cardiac involvement is present. And by imaging, we were able to detect all the patients except 1 that were known to have cardiac AL, but we also picked up patients who were either suspected or no evidence at all of clinical involvement, also had cardiac amyloid. In the liver, it's a very unappreciated organ in patients with AL. Only 2 were absolutely known, 1 was suspected, but we were able to demonstrate liver amyloid in at least 6 of the patients we've looked at. The spleen also, as I mentioned, is a very hard organ to demonstrate unequivocally there's amyloid present. Only seen clinically in 1 patient, but we saw it in quite a few of our AL patients. And the same with the kidney. We were able to detect many of the kidneys that were known to be clinically involved, but also detected amyloid in kidneys that were not clinically appreciated at the time of imaging. So I think we can add some more information to the story about how much amyloid there is and in which organs it is. So what have we learned from the study so far? So the infusions we've done of the peptide have been extremely well tolerated. Imaging at 5 hours post-injection is not too arduous for the patients who come and visit us, and the images provide great resolution of uptake versus background. We've been able to image diverse organs and multiple tissues, so we can image the heart, liver, spleen, kidney, but also adrenals, pancreas, and hopefully we think amyloid in the tongue. In addition to AL kappa and AL lambda, we've imaged at least 5 different types of amyloid as well, so that demonstrates the pan-amyloid reactivity. And the data suggests, based on some of the clinical biomarkers, that we can identify amyloid, particularly in the heart, but also in potentially in other organs, before there are changes in the biomarkers indicating organ issues, organ dysfunction. And so we think we might be able to see very early stages of amyloid disease. So the peptide is now being developed by a company called Atralis as a clinical agent for the detection of amyloid by PET-CT, and we're working to set up a pivotal phase 3 that would allow us to move forward with a new drug application. Hopefully that'll happen sooner rather than later. We're enthusiastic, excited about that prospect. And as Muriel knows, I just spend all my time now sitting at the kitchen table or in my office, and I work with an incredible bunch of people. And I want to thank Muriel and everybody else for inviting me here, and the guys that I work with. So thank you for that.
Thank you so much. That was really, every time you make a presentation, we learn something new. This is really exciting. It was exciting to see the tongue involvement this time in the imaging, because we know that about 20% of our patients do present with an enlarged tongue. What were the major surprises when you went? How many people went to you thinking, okay, I've just got kidney involvement and found out they had heart and spleen? Or how many went to you with cardiac involvement and were surprised to find out that they had kidney and spleen involvement? Or can you tell us a little bit about that?
Yeah, so what's remarkable is AL patients in particular is that they seem to know, even though they may be treated for they may be a cardiac amyloid patient or a renal amyloid patient, when they come to us, they know there's more than that going on. And so they're expecting to see other things. And it's remarkable how well informed AL patients with AL amyloidosis are. They know a lot about the disease itself. They know what can happen and what does happen. So when they see the images, and we see sort of not much in the heart, but other things, it's always educational, because the patients, when they come, they get to see their images the minute they come off the scanner, and we go through what we can see because it's part of their health information. So we do that, and we have a discussion with them. Again, it's a research tool. It's not clinical. No data should be used, to make clinical decisions. But the other thing we found is a lot of AL patients, they want to know. They want to understand the disease a little better. And I think seeing a picture of it puts things in context that we haven't been able to do before. So it's always a remarkable event working with the patients.
Okay, another question is, I know that you're backed up now until August, you said, with patients wanting to be in on the scan, and I realize it takes money and you're limited on what you can do. But when will you be opening up beyond August? Because you know all the patients watching this, the data was fascinating, and they want to be imaged too. So give us some information on that.
Yeah, so the AL pool, I think we still have slots to image patients. Because of COVID and the travel issues, we've been focusing on folks who don't have to fly to us, because that's still not the safest way to travel right now. So we had somebody who drove 10 days. They took a nice road trip to get from, I think it was Washington State, to get to Knoxville. It took them 10 days to get here on a vacation, and then we imaged them. So it's still, there are still some COVID-based restrictions on the patients we can recruit or who we would feel safe to ask to come to Knoxville. But we do have some slots open, and we will be imaging through at least the end of the year to finish up, if not later. But yeah, the way that we do it right now, we make the doses in the hospital, and so we can only image one patient a week, which is a problem because of the demand, which has been remarkable. But we hope to address that, and this won't be the last that we see of this imaging agent. It will live on.
Okay, great. Thank you. We want you to stick around. We've got some questions. But before that, do any of our physicians have questions of Dr. Wall?
Are you looking at immune response with this agent?
So yeah, one of the criteria for the repeat scanning that we've done is that we have to evaluate the presence of anti-peptide antibodies. But because it's an imaging agent and the radioactivity dose, the way we're doing it, we're not scanning. We have to wait at least a year before we do the follow-up scan. So we are analyzing the blood to ensure that there's no anti-peptide antibodies, which we can measure. But a year after the infusion, it's unlikely that you'll have any anyway. But in the one patient that we've tested, we didn't see any reactivity after a year.
Okay.
Okay. Now let's get to some questions. We have one for our nephrologist here. I have amyloidosis of the kidneys. In addition, I'm being treated for multiple myeloma. My treatment consists mainly of Venclexta, which was venetoclax. I guess we didn't really touch on venetoclax, did we? So we can do that as well. My treatment, okay, my light chain numbers have been improving, but my kidney disease numbers have remained low but moderately steady. Oh, I drink a minimum of 64 ounces of water a day. When working outside, that can go to 96 ounces. What can be done to improve my kidney disease numbers?
Sure. So when it comes to amyloidosis and the kidneys, it is unfortunately not the quantity, but the quality of the light chain that's the problem. So even if you have light chains in very small amounts in the system, they will continue to do leave their bad impact on the kidneys. So we usually have the best chance of improvement, if you would say that, in kidney function only after folks can go into complete hematologic remission. And even then, it takes a year and a half for any of those amyloid deposits in the kidneys to actually get resorbed and to see any meaningful improvement in kidney function. So many times, yes, we see that the kidney function will probably not improve remarkably despite an improvement in the light chain burden. But we have to understand that it is the physicochemical properties or the quality of these light chains, and they could be in very small amounts, yet continue to propagate the kidney problem. So the best chance of a kidney recovery is complete remission in our patients. And we touched upon the water intake question before. So just like we have a thermostats in our houses where our thermostat will turn off the air conditioning after a certain temperature. So kidneys are excellent thermostats, if you may will, for the fluid in our body. So if we keep dumping lots and lots of fluid, they will just, make more urine and get them out. And again, we touched upon that many amyloidosis folks have nephrotic syndrome or protein leaking from the kidneys that predisposes them to swelling and fluid retention. So I would suggest that if any amyloidosis patient has that problem, to restrict their fluid intake.
Okay, great. Okay, here's something we didn't touch on, doctors, which was minimum residual disease. And this is something that I know is something that's very hot in discussion right now, because it's part of how do you measure complete response and if you have any minimum residual disease. So this person's asking a question. We'll start with Dr. Libby on this one. They're asking about your, is there a blood test for minimum residual disease? And then she's throwing an acronym for me, MALDI, MALDI, TOF, MS. what does this test show? So basically, well, let's discuss minimum residual disease and matrix assisted laser desorption ionization time of flight mass spectrometry. Wow.
Actually used to work with the guys to do mass spectrometry, and worked with a guy who helped to develop that crazy term and technology. Well, it's really a very, very sensitive way of measuring free light chains or the M spike. So mass spectrometry just offers us a way to see it at much, much lower levels. And perhaps in the future, we'll be able to use mass spectrometry, whether it's the MALDI time of flight technology or not, will be perhaps in the future, it might replace bone marrow biopsies, but at this time, it's really not there. So it's primarily used in a research setting. But it is an interesting question. It's more sensitive than free light chains. In terms of minimal residual disease, that's a term that primarily applies into multiple myeloma, and it requires a bone marrow biopsy, and then we can use a very specific genetic techniques to see how well we've done at reducing the bad cells in the bone marrow. In multiple myeloma, you would like to be, your goal would be now is to be minimal residual disease negative, meaning we cannot see any abnormal cells in the bone marrow, but you're still not cured even if you're MRD negative. So recently, people have applied that concept to amyloidosis, to light chain amyloidosis. And I think it's a worthy thing to look at, but it is not ready for prime time. And our goal currently, when we're treating amyloidosis, is to get patients into either a very good partial remission or a complete hematologic remission, and minimal residual disease using a bone marrow is not required. It's something that yet will have to be studied further in research trials to see how much value is added with it. So I my goal is, and I think most people's goal is still to achieve either a very good partial remission or a complete remission by free light chains and M spike.
Okay, Dr. Medvedova, do you have anything to add?
No.
Okay, and Dr. Lee?
No, nothing to add.
Okay, great. Okay, as usual, we're going to go over time. I know people are yelling at me, and then at the survey, they're going to say we went too long. So we'll take as many questions as we can. And then I promise you, I will hit up all of the doctors to answer the rest of the questions, which we will put out on our website. So please, and also this webinar will be up in 2 weeks on our website, and it will also be up on our YouTube channel. Here's a question. My insurance carrier provider, Kaiser, allows referrals to Seattle Cancer Care Alliance. If I start seeing healthcare professionals in Seattle, who would then manage my care? Is it possible to still get my weekly chemo meds at Kaiser where I live? What would cause my liver ALT and AST test to spike? My doctor took me off daratumumab and Cytoxan this week, but left me on Velcade and Dexamethasone. Also, I got my first Moderna injection, and we haven't even discussed COVID vaccines, folks, before treatment. Just putting that out there. So that's a whole lot for you, Dr. Lee. I don't know if you remember anything that I just said. So I'll repeat anything you need to repeat it.
Sure, I'll start. So, when you come to a center specialist, we're used to dealing with working closely with local oncologists all the time. So I would say, if you're primarily going to get your treatment at, for example, SCCA or OHSU, and you're going to get everything there, then obviously we would be kind of the ones leading the show. If you want to kind of stay closer to home, coming back and forth is difficult. I think you kind of use us as, an advisor in your back pocket. So we work with the local oncologist to kind of give advice on treatment and maybe warn them about certain side effects to watch out for and how to manage and looking for a response. But your local oncologist will be kind of the person quarterbacking all of the care, because they're the ones that are going to be seeing you in the office. So depending on where you're getting your treatment and how you're doing that, I think we're certainly, all of us, I'm sure, are well versed in working together in a really collaborative way with your local oncologists.
Okay, so basically you're co-treating and you're kind of the mothership and you're co-treating.
Yeah, I mean, I think, you know, the details of things, if you're getting things done locally, I think you would be calling your local oncologist, but relying on your amyloid expert to kind of decide when to change treatment or if the response is, you know, adequate or not, or things like that.
Okay, well, we've got another question I want to get to real quickly. Do the vaccines, and they mean the Moderna vaccine and the Pfizer vaccine for COVID, or perhaps the J&J vaccine, do the vaccines affect the light chain levels?
I have heard discussions about that. I haven't really searched the literature to see if anyone has reported that, but inflammation, infections, renal function, which I suppose could somehow be temporarily affected by a vaccine or the response to a vaccine. Lots of things do affect light chain levels, and they're certainly very unpredictable, and they tend to fluctuate a lot. So it's possible. Will they affect it in a long-term fashion? I would say no.
Okay, what I'm going to do, because we're getting to closing time here, and I don't want to be yelled at. Okay, I take it very personally when the survey people say that the thing went too long. So what we'll do is, physicians, you're all okay with this. I'm going to send you all the unanswered questions, and you're going to respond, okay? And then I will put that out there for all of our patients who took part in today to see those responses, okay? And I do want to thank all of you for giving up, you know, your Saturday. I know that you all probably have other things to do. I don't, but I know that you do. So we really appreciate you doing this. Bob will make sure that the recordings appear in YouTube and on our website in a couple of weeks. Take a look, folks, at the chat. Okay, Paul and Bob have put up some wonderful information in the chat, and we'll be putting that out again for you. So you'll have notice on that. Also check out One Amyloidosis Voice, because they will have information on our webinars as well. We want you to stay safe, fill out that survey, say nice things about the time. We didn't go over, okay? We didn't go under, but we didn't go over, okay? We will see you all soon. Stay safe, and we're just a phone call away. Daytime, please. We're just a phone call away. Thank you all so much. Take care, everyone, and thank you, doctors, amyloidologists. We really appreciate this so much.
Thanks, Meryl. Thanks for everything you do.
Thank you.